Thank you very much for the invite. It's great to see such a large number of you all here. And my title is The Highs and the Lows of Calcium. And of course, calcium is important for all of you, all the patients with AMEND, but also I want to tell you a bit about calcium and how it affects the rest of the population and why it's important. And then we'll get on to how it affects you. Okay? Now, just a bit about endocrinology, because of course you're the multiple endocrine neoplasia group, and I'll just rewind a bit and say some very basic things, which is what we do is study hormones, and the importance of that is they are part of what we call the endocrine system, and its role is to regulate the concentration of everything. Okay, so your blood doesn't change its concentration of most things because of the regulation of the endocrine system, and I'll show you how this affects patients when things go wrong. But basically, cells can only survive with the right amount of glucose, the right amount of calcium, the right amount of all the other substrates that we need to live. Okay, and so we've developed the system to make sure they're all the same. So, for example, we have a system to make sure the calcium really doesn't change. Okay, if you start eating lots of calcium or you eat no calcium, your blood calcium won't change because of the endocrine system. It's the same with, even more important really, glucose and insulin. Okay? If you eat nothing for a week or go on hunger strike even, and just drink water, your blood glucose will hardly change because it's so important to have glucose for your cells to survive. We've developed a system to make sure it doesn't change, and that the regulation there is insulin. Okay? And some people who have got tumours that make insulin will know that that causes lots of problems in glucose handling. The pituitary gland, again, is another important endocrine controller of many, many parts of the body, okay? And then we'll come to adrenaline if we get there. But really, we'll go back to calcium now, and I'll explain how this works. So why is calcium important? And the important thing, really, is that, first of all, it's the main structure of bone, okay? And most of our calcium is stuck in bone. And it is incredibly strong. It's stronger than steel when it's correctly arranged, as it is in bone. Okay, so that calcium, together with other salts like phosphate and magnesium, form this very, very strong skeleton, really, which enables us to survive. Okay, and if you ask an orthopedic surgeon, he will tell you that this is not a skeleton, nothing with calcium. Okay, its role is to be structural framework, to be really strong. It's amazingly light, considering how strong it is. If we were made of steel, we'd be much, much heavier. So it's a very, very efficient way of carrying our weight around. Of course, it protects our vital organs, and it grows in a very clever way, and it remodels depending on how it's used. Okay, so it's a very efficient use of calcium, but there's lots of calcium. So of the calcium in your body, 99% is in bone, and it stays there. Okay. Now, from my point of view, the skeleton isn't for that. It's really as a store of calcium, so that if we don't eat calcium, we run out of calcium, there's a huge store that the rest of the body can use. Okay? It's a reservoir, I would say, of calcium, phosphate, and magnesium. So your bones have a nice store of calcium in case of trouble. Okay? There's a tiny, tiny amount of calcium in your blood floating around the circulation, and it has very, very important roles. Okay, first of all, it's a messenger between cells. Okay, so that, let's say one of your brain cells wants to talk to your hand muscle and make it contract. I decide I want to contract my arm. There are lots of neurons between the brain and the hand, but they all secrete calcium as the messenger to tell the next neuron to fire. And calcium is really, really important in nerve muscle transmission. So if the level of calcium is not normal, nerve muscle transmission will start to fail. Okay? And it's not just nerve muscle, it's nerve to nerve. So within the brain, communication will start to not be correct. And that might explain why people, because I don't know how the brain works. Like, I don't know why I feel happy when good things happen and unhappy, but the brain regulates communication through calcium. So if calcium is not correct, it might affect how I feel. Okay, and that's an important thing to bear in mind. So that's what the free calcium floating around is important for, controlling nerve muscle transmission, which means if it goes wrong, there's a good chance that one won't survive. Okay, without calcium, lots of things can go wrong. So because we've got this endocrine system, we maintain our calcium to a very tight regulation, okay, and we measure it here in millimoles per litre. And if we take blood from 1 million people who have not got any tumours and are well, it will not vary between 2.2 and 2.6. It's a very narrow window, okay? And if the calcium falls below that, things happen to bring it back up again. And I'll show you how that works too. Are there any questions? You're all sitting very quietly. If anyone's got any questions, just put your hand up and interrupt, okay? Because you mustn't keep wondering what I'm talking about in case I'm... Okay, so if you have any questions, just put your hand up and ask, okay? Okay, so here is an important part of the whole of endocrinology, okay? And it starts with negative feedback. And negative feedback is a very, very important mechanism for all of endocrinology. But let me show how this works, okay? So this is my, do you like my drawing here? There's a nice thyroid gland, okay, with 4 parathyroid glands, green ones, and they secrete the hormone PTH, parathyroid hormone. And this is a receptor, R, okay? Now, supposing my calcium is low, right? The parathyroid glands have got receptors for calcium, and they say, oh, the calcium's falling a bit, we'd better do something about that. And they release PTH. So PTH is a messenger that our calcium's a bit low, so the PTH level rises. And that goes to your bone, to your kidney, and to your bowel. All 3 organs will do something to increase the calcium back to normal, okay? So for example, bone will release a bit of calcium, the kidney will stop peeing out calcium, will retain the calcium, so urine will have less calcium in it, and your bowel will start to absorb calcium better from everything that you've eaten. And that will bring the calcium back up to normal, which will feed back here to a normal level of calcium, and then that path will be happy they've done their job and they'll stop making PTH. And that system keeps the calcium absolutely stable on a day-to-day basis. Now, if you start eating loads of calcium, okay, the pH will fall a bit, and that will reduce all this effect, and your calcium won't rise too high, okay? If you suddenly end up in a part of the world where there is no calcium in the diet, then this mechanism will increase the PTH, and you will absorb calcium efficiently, and you'll retain it from your kidney. You won't lose it at all. So your calcium does not change. Now you can see this depends on your parathyroid glands working all the time. And most people take them for granted, they don't even know they have them, okay? But they are doing this important job all the time, okay? And if they go wrong, you can see there'll be lots and lots of consequences. Okay, so that's how it's controlled. The level in the blood then is important, I'm just recapping this, for nerve muscle function. It's really crucial for survival, therefore. And therefore, the concentration must be maintained despite lack of calcium and vitamin D deficiency. Okay, and I'll come to vitamin D, because vitamin D has another important angle on how it controls calcium. So if you have a long period, okay, of lack of calcium and lack of vitamin D, the outcome, because it's so important to maintain my blood calcium, that my bones will suffer. My bones will release calcium because it's so important, okay? And the bones will take secondary place, okay, until eventually they start to fracture, which is not a good thing. But in the short term, it's my reservoir, keeps me alive, maintains my blood calcium. Now, this is from a very old textbook. This is from when my father was a medical student, and this is from a book drawn by an artist that is remarkably accurate from about 1950, okay? And the only thing that isn't quite right is that he's missed out vitamin D. But I'll just run through this because it really has a lovely, clear explanation of how the parathyroid glands work, okay? So here are the 4 parathyroid glands in the neck. And you'll see in green he's drawn the hormone, parathyroid hormone, correctly. And he's pointing out this red thing here is the blood flowing around the circulation, okay? Here is the stomach and the gut on the left-hand side. On the right-hand side is an example of a nephron in the kidney, okay? And then at the bottom here is my bones, full of calcium and phosphate, okay? And he's showing very clearly that the regulation is by this thing here. So the calcium level falls, then that stimulates the production of the parathyroid glands to make some PTH, and the PTH goes to your gut. He didn't quite understand vitamin D, but he put down that vitamin D is something clever here, and the calcium is absorbed better from the gut, okay? And then some of the PTH goes to the kidney, okay, and it causes you to lose phosphate and retain calcium. The calcium level comes back up in the blood, okay, because you don't lose it. So the kidney filters the blood, okay, and you basically lose all the waste products, and the calcium then is resorbed back into your blood under the influence of PTH. And the third important thing is that when your calcium is low, it turns on this cell called the osteoclast, okay? And the osteoclast makes a little hole in the bone and pushes out some calcium, okay? So that's how you make your calcium level normal. And because we eat some calcium, and in general, the bones don't suffer because all the osteoclast is activated. As soon as the calcium will come back to normal, the osteoblast, this bone-forming cell, will make a new bit of bone and fill up the hole. So your bones are turning over all the time, but they basically are strong, and they'll maintain their strength as long as we don't have a long period without calcium. Okay, and this basically explains most of how this works. There's one missing bit, and it's important for the parathyroids, and that is that vitamin D is another very important controller of the absorption of calcium. And vitamin D is controlled by the kidneys, okay? And what happens is vitamin D, if you eat some vitamin D, it's absorbed, goes to the liver, it's activated partly to this 25-hydroxyvitamin D, and then the important step is the enzyme in the kidney called 1-alpha hydroxylase. And many of you have heard the term 1-alpha and maybe on 1-alpha, and I'll come back to what that is. But essentially, the enzyme 1-alpha activates vitamin D, and then the 1-alpha vitamin D then is the substance that can cause calcium to be absorbed. So 1-alpha hydroxylation, activation of vitamin D, is controlled by PTH. Okay, and that means that if you haven't got any PTH, your vitamin D also will not be activated. Okay, so PTH has a lot of important roles. Now, are there any questions about what I've said so far? Anyone got any thoughts or, yeah?
Just a thought, I just wondered what speed the osteoclast would work on the bones to get the calcium back into the blood.
So the really clever thing is it's happening all the time. So it's instant, because what's happening, right, is that my osteoclasts are making little holes all the time, and my osteoblasts are filling them up all the time. So it's a bit like making a hole and filling it, making a hole and filling it. And what happens is if I have a bit more PTH, then I'll make a slightly bigger hole, and I wouldn't fill it quite so much. So within minutes, the calcium comes back up to normal, because I just changed the rate of those two things. So bone is turning over all the time, and all I need to do is slow down my bone building, and my calcium will shoot up. So it's a very, very, very quick effect. Any other questions? Yeah.
Are there particular bones that release the calcium?
Yeah, yeah. All of them will release calcium, but they're controlled by different hormones. Okay, so for example, if you have a bit too much PTH, then although all the bones suffer a bit, the ones that go first are the ones around the wrist. Okay, but they all will lose a bit of calcium. But we know in hyperparathyroidism, if you check the bone density, the ones that are most affected are the bones around the wrist. So that's why Colles fractures start happening more in such people. Okay, but all the bones will suffer a bit. And of course, there's a lot more bone in some parts of the body than others. So other conditions, for example, well, in fact, some we've affected. There's a condition called Cushing's disease, where there's too much steroid. That causes excess loss of bone from the spine. So different conditions cause different losses of bone. But in the case of the parathyroids, it goes for the wrists. Okay, and hyperthyroidism also goes for the spine. So you get spinal osteoporosis if you've got too much thyroxine over a long period. Okay, so that's a bit about regulation. Okay, so now let's think about what happens when this nice negative feedback loop that's really fantastic, controlling everything, goes slightly wrong. Okay, so we've said so far that PTH levels go up when the calcium is low. That's when they should go up. And this is what PTH would cause. Okay, calcium comes out of bone, activate the kidney enzyme 1-alpha hydroxylase, and therefore increase your blood calcium by those two mechanisms. The bone thing is instant. The 1-alpha hydroxylase is a little bit slower. So both activities will increase the calcium over time. Okay. Okay, so if we go for a bit of calcium deficiency, this is what should happen. Homeostasis, the maintenance of normal calcium. For some reason, you can't get hold of calcium in your diet. The calcium level falls from 2.40 to 2.39. It's still in the normal range. It just starts to fall. Immediately, the parathyroids are onto it. They make a bit more PTH, sacrifice a tiny bit of bone somewhere, comes back up at 2.4. Okay, so if you check your calcium on a daily basis, it is the same. Okay, whatever you do. So this is the same textbook showing the effects of primary hyperparathyroidism, okay? And you can see that Nett has drawn, he says here that 80% of patients who have sporadic hyperparathyroidism have just one gland. In other words, one gland just becomes autonomous by itself, okay? And that is the usual case, and it says 80% of people, and this applies to people who have not got AMEN1 or AMEN2. It's just a random event. One cell becomes a bit tumorous and it makes too much PTH, okay? And then he says there are some other ones, okay? For example, there's the primary where you get, he says here, about 10% of cases. Now, this is before they understood AMEN, this textbook was written, okay? And he's saying it's odd that there's more than one. Isn't that strange? There's 2 or 3 glands become overactive, and there's no family history behind this. But of course, this is clearly part of all the genetic causes of primary hyperparathyroidism, okay? Because if 2 glands become autonomous, you'd be really unlucky in his view. And yet it's 10%. So there must be something else. And that, of course, is the genetics that are driving this. In other words, if you've got a gene that makes hyperparathyroidism more likely, then it might happen in 2 or 3 of your parathyroids, okay? But if you haven't got that gene, most people present with just one gland that's overactive, okay? And 80% of cases have this usually single gland. Take it out, and we can cure them. So what he's pointing out then is whatever your cause of hyperparathyroidism, okay, this is the outcome on the patient. First of all, there's a huge excess of PTH going down here to bone, so very active osteoclast, and he's pointing out that there's subperiosteal resorption. In other words, the bone is full of holes. It's been resorbed and it gets thin, and if you leave it for long enough, they'll fracture, okay? And meanwhile, the bone building has not sped up, so the bone is getting thinner and thinner and thinner over time, because the message coming from the parathyroid is saying the calcium is low. But it's not. It's an error, because the parathyroids are doing their own thing. They shouldn't make PTH if the calcium is not low. The calcium is now high, and the parathyroid gland is just carrying on regardless. It's making PTH, signaling to all the cells that there's not enough calcium around. That's an error. And so the bone is releasing calcium, the kidneys are resorbing or trying to resorb calcium, and there's a huge amount of calcium being filtered in the nephron, okay? And of course it's going to keep on doing this because the regulator is telling it to do so, because it is making a mistake, because it's a tumor now. It's not behaving like it should. So if the regulator fails, it's going to keep on going and it won't stop, okay? So bone get thinner and thinner. You lose all this calcium. So as he's pointing out here, he says serum calcium moderately or markedly elevated, very, very high calcium. That calcium is filtered, okay, and it's such a high level of calcium that it can't be reabsorbed, all of it, and therefore you see these stones, and as he's pointing out, the calcium forms stones because it's in the wrong place. So the bones lose calcium, then in the kidney, and then you get kidney stone. Okay, you don't want calcium in your kidneys, you want them in your bones. So what's happened is it's been transferred, and as he's pointing out, he's drawn a nice big renal stone here at the bottom there. So this patient has got a big renal stone because the calcium has been lost for a long time from the bone, getting into the kidney, and although you're peeing out a lot of calcium, you're also making some stones. So that's the second problem. The third is, as I told you, it's important for nerve muscle transmission. So all that's going to start to fail, okay? And it's not going to work properly. Now, what tends to happen is it changes people's thinking and mood because it has an effect on all the brain cells. Okay, so that's an important cause of hypercalcemia, too much PTH. And if you've got AMEN1 or AMEN2, then you're at risk of primary hyperparathyroidism. In fact, in AMEN1 it's very common, and AMEN2 it's quite common. I think we can summarize it as that. The outcome, if people don't know, okay, if people don't look for it, eventually is fractures of the bones, okay, stones in the kidney. Some people become very unhappy and sometimes even psychotic because of the calcium effects on the brain. And the other thing is the bowel. Your bowel, of course, is full of nerves which cause peristalsis, food to move from the top to the bottom. And of course that fails to happen properly, and so because they can't contract properly, patients develop constipation and abdominal pain. Okay, and these are important specific things that happen in patients who have got hypercalcemia. Now this is a more complete list of what patients say or what we have found happens in undiagnosed hypercalcemia. Okay, so this really is more common in patients who either have AMEN1 and don't know, or patients who've not got MEN1 and just happen to have primary hyperparathyroidism by chance. And they go for years undiagnosed, okay? Because unless someone measures their calcium, you wouldn't know, okay? And so they lose their appetite a bit. They feel weak because the muscle transmission isn't working properly. They feel tired and depressed. And of course, we blame, there's lots of factors that affect depression, okay? And I don't know what makes people depressed. What is it, do you think? If I win £1 million, I feel great. Why is that? What is the mechanism of that feeling great, okay? And similarly, if bad things happen, why do I feel down? What is the mechanism of that? Is it calcium? We don't really know what it is. But certainly, patients who have got abnormal calcium levels feel depressed without explanation more often than you'd expect. And then sometimes, eventually, people become unconscious, okay? In your heart, because the calcium is important in the little arterioles and how tightly they compress, you have a higher incidence of hypertension in patients who've got hypercalcium, high blood pressure. And the heart rhythm can be affected. So although your heart is beating at a very constant rate normally, sometimes you get an arrhythmia, an abnormal rate of the heart. We talked about kidney stones already. Polyuria and polydipsia, that's medic speak for peeing too much and drinking too much, okay? And that's because the calcium in the urine, by osmosis, draws water with it, so you end up passing more urine, and of course you feel more thirsty. And then the GI tract is badly affected too, okay? And of course, this is not all patients have it, but some patients are more likely to get peptic ulcers. Sometimes they get a very dangerous condition called pancreatitis. You can get gallstones, that's cholelithiasis, gallstones, and we mentioned earlier about constipation. And lastly, I thought I'd put the thing in called band keratopathy in the eye. If you have a long period of hypercalcemia, the calcium precipitates on the eye, and you can see that in this form of band keratopathy. Now, that's a nice full list, okay, but to the medical students, because we've got to make sure that everyone's aware of this, okay? And so what I teach them is bones, stones, moans, and groans are the features of primary hyperparathyroidism, okay? And it's important because if you put them together, then people will remember them, okay? Otherwise, they won't. Because, you see, patients don't come along and say, I've got an endocrine condition and I've had a fracture. It happens one by one, and unless someone puts it together, it gets missed. So these are the things that happen, okay? Fractures, kidney stones, depression, and abdominal pain. Bones, stones, moans, and groans. And here is this a picture from Netta, my favourite author, showing the features of primary hyperparathyroidism. So he's got kidney stones, okay? He's showing the skull. You can't see it very clearly on that, I don't think, but it's got lots of little black holes, a salt and pepper skull. Now, this was in the days when calcium was difficult to measure, so patients went for years undiagnosed with hyperparathyroidism. And you can see this skull is full of holes because the calcium has been lost over years and years and years, okay? And he's pointing out the cystic fractures in the bones. And you see this patient's eye? There's little calcium deposits around here. That takes years and years to develop. So you'd rarely see that now with our hopefully good medical care. But this patient has been hypercalcemic for many, many years and not known. And he's got band keratopathy, a little bit of calcium depositing on the front of his eye. Okay, and interestingly, okay, and obviously he didn't know about AMEN1, but he's pointing out, because what he did was he studied lots of patients and drew them. And he's pointing out that some of them, he looked multiple adenomas, pituitary, thyroid, pancreas, and adrenals. Okay, he's pointing out that these patients seem to have these other things as well. Isn't that interesting? Okay, some of them had multiple adenomas. Okay, not knowing that there's a condition coming up called AMEN1 in 30 years from now. So that's what I like. It's full of real history, and he's studied this, and without understanding, he's drawn it and left it for us to think about. So that's hypercalcemia, too much PTH, primary hyperparathyroidism. I need to talk about the lows as well, and of course the lows are caused by people like Tom, who take out the parathyroid glands and cure the primary hyperparathyroidism and leave you with hypoparathyroidism, okay? So a low calcium isn't something that happens spontaneously. A low calcium is caused by surgeons, okay? Now that's a good thing because leaving it high, as I told you, is a bad thing. It has all those terrible effects on you. It's very controversial as to what one should do and when, because I've told you lots of bad things about hypercalcemia, okay? But of course, hypocalcemia has a lot of bad things too, and what you want to have is a normal calcium. And one of the problems with parathyroid disease is because if you've got a genetic cause, we know that if we take the one that's tumorous out, that you've got 3 other troublemakers and one of them might go off in the next few years. There's a lot of discussion about what to do. Whether you take them all out, whether you take some of them out, leave them behind and then be upset when the other one becomes hypercalcemic. Of course, if you take them all out, then you will have trouble. You will become hypocalcemic because the regulator will be gone and there'll be no mechanism to maintain your blood calcium. Okay, so that's an issue. So let's think what will happen. Let's say Tom takes out all the parathyroid glands, so there is no PTH. Okay, what will happen is the calcium will fall because the bone osteoclasts will turn off. They'll slow down because there's no signal to say send out some calcium. So the bones will then suck in all the calcium that's around, and your blood calcium will fall lower and lower and lower. Okay, and the kidneys will also excrete calcium, and so the calcium will keep falling. And because you're not going to activate any vitamin D, you'll stop absorbing calcium from your gut as well. Okay, so by every method, you'll be losing calcium. That's what regulation does. And the outcome is nerve muscle transmission goes all wrong again. Okay, and what happens is the muscles, instead of becoming less active, become very irritable, and so do the neurons become irritable. Okay, and what that means is, you see this picture here, this is what doctors do to patients. Okay, they punch them in the face, okay? And that's called Tvostek sign. And do you see how her face is twitching? Now, that doesn't happen if your calcium's normal, but if you've got a low calcium, all your muscles are very hyperexcitable, and you just tap them once gently and their face contracts very violently, okay? And that was described by a guy called Tvostek, who said, if you see that, that means the calcium is really low, and you've got to do something about them, give them some calcium, okay? And of course, they recognize this as a complication of surgery of the neck. If you remove the parathyroid glands, your calcium becomes low and you get irritable neuromuscle transmission. So the other sign you see is a thing called Trousseau sign, where if you take the blood pressure, as you put the pressure cuff up and up and up, the muscles of your hand start to contract involuntarily, okay? You can't relax them. Okay, and that's called Trousseau sign. Similarly, he's pointing out that when you check the reflexes, they're very brisk. You tap the knee and doing, it goes out because they can't relax. And when it gets really bad, you have a fit, an epileptic fit, convulsions, okay, because all the neurons are not able to suppress themselves, and so one neuron fires and they fire all the others, and you have an epileptic fit. And that, of course, is dangerous, okay? So all this together means that when the calcium is low, we don't like it. And when we see these signs, we think it's an emergency, because if you leave them for a few more hours, they'll have a fit, okay? That's the complication of severe hypocalcemia, is an epileptic fit. And also an arrhythmia might happen. Okay, and so what we've got to do is replace the calcium, bring it back up to normal. And people say, oh, that's easy. Just have some tablets of calcium. And you take the calcium by mouth, and up will come your calcium. But it won't, because if you've got no PTH, then you take the calcium by mouth, it won't be absorbed. And if it is, you'll pee it out, because the kidneys will excrete it, because there's no mechanism to keep it in. And so we need to get some PTH activation back to make sure that the body keeps that calcium. Otherwise, it will be very difficult to treat the low calcium. So I've added on here the other step that Netta didn't know about, and that is this step here, the 1-alpha hydroxylation of vitamin D, which is also controlled by PTH. And of course now, instead of just getting normal vitamin D, okay, we can actually get some activated vitamin D. So vitamin D comes as, just by the way, 2 forms. There's vitamin D3, which is an animal product. Humans make it in the skin. And if you want to buy it, it actually comes from lanolin, okay, which is obviously sheep wool fat. And vitamin D2 is a plant ergocalciferol. And both work, but they're both inactive when you take them by mouth, okay? So there's D3 and there's D2, and you can take it by mouth. And this is the stuff you can buy over the counter. This is inactive vitamin D, okay? It's effective if you have parathyroid glands that work, but not effective without PTH. But you can buy them over the counter because it's regulated by the body. Okay, if you take too much vitamin D, it doesn't matter, because the parathyroid glands will suppress the absorption of any calcium. So this is, you don't need to get a license. This is non-licensed but very effective vitamin D. Okay, and this is all available over the counter. But it won't work if you haven't got PTH, because you haven't got the enzyme 1-alpha hydroxylase, because the kidney is not active because it requires PTH. And so if you have no PTH, what we do is we give you 1-alpha hydroxy vitamin D, as you'd call it 1-alpha. And if you take 1-alpha, then you don't need the parathyroid gland to regulate that. But someone needs to keep an eye on your calcium because the magic autoregulation is not happening. The magic control is not there. So if you take a bit too much 1-alpha, the calcium will go back up and up and up, because what's happening is the blood test that you have is the regulator, because there's no internal mechanism now. You've lost that. So if you have hypoparathyroidism, then you can take calcium and 1-alpha calcidol, and that will maintain your calcium nice and normally, but someone's got to measure it a lot because your parathyroid glands aren't doing that job. And if they do that, then you'll be fine. It's called 1-alpha, by the way, because of the way that that steroid molecules and cholesterol are numbered. And of course, let me show you this. Yeah. So this is position 1, okay, 2, 3, 4. They've numbered them all, and that's position 25. And so if you put an OH group, that's hydroxylase, on position 1, then that's 1-alpha hydroxyvitamin D. And that's why it's called 1-alpha, because there's an OH group stuck on there. And that's the critical bit making it active. So basically, the treatment of hypoparathyroidism is to give some calcium, and the pTH is low, and so we need to give some 1-alpha as well. And if we do that, we can get the calcium up to normal. Now that sounds easy, but it's not, because it's very difficult, because you're missing the daily regulation that happens all the time. So you've got to keep on adjusting the dose of 1-alpha and calcium to try and get it right. And if you over or undershoot a bit, then the consequences of what you saw happen. So it's really important to keep an eye on that. Maybe I'll stop there. There's a summary, okay? It's really important we have constant, stable calcium levels. If they aren't stable, your nerve, muscle and brain will suffer. If your calcium is high, we can cure it with surgery. And if it's low, then you need the physicians to keep your calcium levels up. And I'll stop there and take any questions, and thank you all very much. There's 2 questions there at the back.
When you say about having regular blood tests to check to see whether the 1-alpha is working,
Yes.
how often would regular be?
Okay, so your parathyroids are measuring it every minute, okay, which is obviously ridiculous. Early on, we do them a lot, okay, because basically the other thing I will say is that all of us are creatures of habit. And so what happens is that if you start eating a similar amount of something, you might find that you have a calcium check and actually it doesn't change at all. So what we do is, after you've had surgery, it shoots up and down, so it's mayhem, and then after about 3 months it becomes more stable, because the bones have a more stable level of calcium once they've got to that 3-month window. And there are some patients that only need it checked once a year, and there are others who need it checked every month. So you check the level, and if it's changed a lot, then we do it again frequently. And if it's nice and stable, you can leave it, because it depends on what you all do. So supposing you decide to go on a Sahara trek, okay, you might need it slightly more often than if you're having your daily diet that you normally have, because it is remarkable, in fact, if you do diet cards on people, you find they eat the same thing every day. We rarely change, okay? So the answer to your question is, it varies depending on what you're doing, and most people, once you're stable, can have it done once a year. If you have any change to your medication, you must do it more often, because if you, let's say I put the dose of 1-alpha up by 20%, then the calcium will start to drift upwards very slowly, and so you need regular blood tests. But once you're on the same dose of calcium 1-alpha, then you can stop doing that. Another question there.
I've got a couple, if that's okay. The first thing is, if there's PTH in the blood, then one might still get tetany,
Right.
which seems a bit bizarre. I can't equate that one. And the other one is, if there's a problem with the gut, with hyperparathyroidism,
Yeah.
could that predispose you to other gut disease? Maybe like irritable bowel syndrome?
Okay, they're very good questions, and the answer to the latter one is yes. So the thing about PTH being present, so there needs to be the right amount of PTH. So if you have intact parathyroid glands, then the amount of PTH will regulate the calcium perfectly without any problems, and you won't have tetany. But if there is not enough PTH, when the calcium falls below 2.2, then tetany is the description of an irritable neuron or irritable muscle, then you'll get it. There are other factors that cause tetany. So for example, there are some so-called completely normal individuals, normal parathyroid, normal PTH, whose ionized calcium becomes low when they overbreathe, for example. And you can get tetany with totally normal calcium handling, because if you overbreathe, then the amount of carbon dioxide in your blood falls. So CO2 is a waste product, as you all know, and if you overbreathe, you blow it off. So it actually has an important role at maintaining the acidity of your blood, because CO2 is an acid. And if you blow that off, the pH of your blood changes. And so what happens is the ionized calcium then sticks more strongly to proteins, and the outcome is that you get tetany even with a normal calcium. So although I'm talking about calcium, there are other mechanisms that control nerve and muscle. So one of those might be the mechanism. Can I just check, do you want me to keep going with questions, or how are you doing for time?
Yeah, I was going to actually get in here and be bossy. And
Yes.
say, actually, because we're a little bit behind time, you've got an hour and a half with the entire panel later. So if we'll do detailed questions at the end this afternoon, then that would be great, and then we can speed things up.
Okay.
But thank you very much.
Not at all.
That was great.